This is Dr. Dhanalakshmi from the Department of Oral Maxillofacial Surgery, Sri Balaji Dental College. Today we are going to discuss about local anesthesia and general anesthesia. Contents: definition, classification, mechanism of action, composition, local anesthetic agents, vasoconstrictors. Definition of local anesthesia: it is the loss of sensation in a circumscribed area of body caused by a depression of excitation in nerve endings or an inhibition of conduction process in peripheral nerves. Classification: local anesthetics are classified based on two groups, esters and amide group. Under esters group, esters of benzoic acid, example butadiene, cocaine, benzocaine, tetracaine. Whereas examples for esters of para-aminobenzoic acid is chlorprocaine, procaine, propoxycaine. Amides contains atricane, bupivacaine, dibucaine, etidocaine, lidocaine, mepivacaine, prilocking, ropivacaine, quinoline, centibucardine. Esters versus amides. The ester linkage is more easily broken, so the ester drugs are less stable in solution and cannot be restored for as long as amides. Amide anesthetics are also heat stable. The metabolism of most esters results in production of para-aminobenzoate, which is associated with allergic reaction. Amides, in contrast, very rarely cause allergic phenomena. For these reasons, amides are now more commonly used than esters. Based on mode of application, local anesthetics are classified into injectable versus surface or topical anesthetics. Example for injectable local anesthetics are low potency of short duration, example procaine, intermediate potency and intermediate duration, example lignocaine, high potency of long duration, example tetracaine, bupivacaine, ropivacaine, dibucaine. Example for surface or topical anesthetics are based on that it is classified into soluble and insoluble. Soluble surface or topical anesthetics, example cocaine, lignocaine, tetracaine, benoxynate, whereas insoluble local anesthetic are benzocaine, butyl amino benzoate. Based on the duration of action, local anesthetics are classified into ultra short acting, medium acting and long acting. Examples for ultra short acting are procaine without vasoconstrictor, 2% lidocaine without vasoconstrictor. Example for short acting are 2% lidocaine with 1:1 lakh epinephrine, 4% Prilocking when used for nerve block. Example for medium acting is that 2% lidocaine plus 2% mepivacaine with the vasoconstrictor and 4% Prilocking with 1:2 lakhs epinephrine. Example for long acting is 0.5% bupivacaine with 1:2 lakh epinephrine. According to biological site and mode of action, it is classified into four categories. Class A, at receptor site on external surface of nerve membrane, biotoxin, tetrodotoxin. Class B, at receptor site on internal surface of nerve membrane, quaternary ammonium analogues of lidocaine, scorpion, venom. Class C, by a receptor independent physiochemical mechanism, benzocaine. Class D, by combination of receptor and receptor site. Clinically useful local anesthetic agents. Mechanism of action of local anesthetics are altering the resting potential of the nerve membrane, altering the threshold potential, decreasing the rate of depolarization, prolonging the rate of repolarization. In step 1A, an initial phase of slow depolarization, the electrical potential within the nerve becomes slightly less negative. 1B shows falling electrical potential reaches a critical level. It gives the result of rapid phase of depolarization, and this is termed as threshold potential or firing threshold. In 1C, this phase of rapid depolarization results in a reversal of electrical potential across the nerve membrane. Electrical potential of plus 40 millivolts exists on the inner surface of the nerve cells. Effect of pH. Local anesthetics are weak bases and are usually formulated as the hydrochloride salt to render them water soluble. At chemical titration, the protonated and unprotonated forms of molecule exist in equilibrium, but only the unprotonated molecule diffuses through the cell membranes. Once inside the cell, the local anesthetic will be in equilibrium with the formation of protonated form, which does not readily pass back out of the cell. This is referred to as ion trapping. As we have seen previously, local anesthetics are weak bases and their activity increases by increasing the pH. This because if large amount of a drug is unpolar, it will facilitate its penetration through the cell membrane. Once the drug has penetrated the lipid barrier and it reaches its site of action, it is ionized, and the ionized form is responsible for the local anesthetic activity. Acidosis such as caused by inflammation at a wound partly reduces the action of local anesthetics. This is partly because most of the anesthetics is ionized and therefore unable to cross the cell membrane to reach its cytoplasmic facing site of action on the sodium channel. Local anesthetics block conduction in the following order: small myelinated axons, example those carrying nociceptive impulses, non-myelinated axons, and then the large myelinated axons. Thus, a differential block can be achieved, that is, pain sensation is blocked more readily than the other sensory modalities. Disruption of ion channel function via specific binding to the sodium channels, holding them in an inactive state. Disruption of ion channel function by the incorporation of local anesthetic molecules into the cell membranes. Small nerve fibers are more sensitive than the large nerve fibers. Myelinated fibers are blocked before non-myelinated fibers of the same diameter. Thus, loss of nerve function proceeds as loss of pain, temperature, touch, proprioception, and then skeletal muscle tone. This is why people may still feel touch but not pain when using local anesthesia. Theories associated with local anesthetics are acetylcholine theory, calcium displacement theory, surface charge theory, membrane expansion theory, specific receptor theory. In this slide, we are going to see about the mechanism of action of local anesthesia. Calcium ions displaced from the sodium channel receptor site, followed by local anesthetic molecules binding to that site. This leads to blockade of sodium channel. There will be decrease in sodium conduction, depression of rate of electrical depolarization, failure to achieve the threshold potential, lack of development of action potential, leading to conduction blockade. Duration of action. The duration of action of the drug is also related to the length of the intermediate chain joining the aromatic and amine groups. Protein binding procaine is only 6% protein bound and has a very short duration of action, whereas bupivacaine is 95% protein bound. Bupivacaine has a longer duration of action. Absorption and distribution of local anesthetics. Some of the drug will be absorbed into the systemic circulation. How much will depend upon the vascularity of the area to which the drug has been applied. The distribution of the drug is influenced by the degree of tissue and plasma protein binding of the drug. The more protein bound the agent, the longer duration of action, as free drug is more slowly made available for the metabolism. Metabolism and excretion. Esters except cocaine are broken down rapidly by plasma esterases into inactive compounds and consequently have a short half-life. Cocaine is hydrolyzed in the liver. Ester metabolite excretion is renal. Amines are metabolized hepatically by amidases. This is a slower process, hence their half-life is longer and they can accumulate if they are given in repeated doses or by infusion. Adverse effects of local anesthetics. In the central nervous system, excitation followed by depression, that is drowsiness to unconsciousness, and death due to respiratory depression. In the cardiovascular system, it leads to bradycardia, heart block, and vasodilation. Allergic reactions, allergic dermatitis to anaphylaxis, rare but occur most often by ester type of drugs. Composition of local anesthetic agent. Lidocaine 2%, vasoconstrictor, adrenaline, sodium metabisulfate 0.5 mg, methylparaben, thymol, water, sodium chloride, phentolamine. Instead of methylparaben, capryl hydrocaprinotoxin can be used. Now we are going to see about local anesthetic agents in detail. First, we are going to see about ester derivatives. Example, procaine. It is nothing but diethylamino ethyl ester of para-aminobenzoic acid discovered by Einhorn in the year 1905. It is available as 4% solution. It is also available in 2% solution in combination with 0.4% propoxychene and 1:30,000 levortinerol or 1:20,000 levonorepinephrine. Procaine is a white crystalline powder slightly soluble in water, most commonly used as hydrochloride salt. Procaine is comparatively weak anesthetic of low degree of toxicity. Standard of toxicity and potency assigned a potency and toxicity of 1. It is also a profound vasodilator, 0.5 to 1 gram slowly sufficient over period. Procaine is hydrolyzed to para-aminobenzoic acid and diethylaminoethanol within the plasma. Onset of analgesia depends on the concentration and method employed. When infiltrated around free nerve endings, onset is almost immediate. Pulpal analgesia is about 30 minutes. In this slide, we are going to see about the effects of procaine in the central nervous system, cardiovascular system, and respiratory system. In central nervous system, it readily crosses the blood-brain barrier, produces both stimulation and depression of the central nervous system. In cardiovascular system, it mainly depends on the amount of drug used. Systemically, it depresses more cardiac and skeletal muscles. Effect on heart is like quinidine. In large doses, it may produce hypotension. In respiratory system, it has a little direct effect. Next, we are going to see about tetracaine. Tetracaine is nothing but para-butyl aminobenzoyl 2-dimethylaminoethanol hydrochloride. It is a white colorless powder soluble in water, that is 1 gram in 7 ml of water. It is used as hydrochloride salt with a pH of 5.9. It is potent, relatively toxic local anesthetic agent. It is rapidly decomposed by alkali. It has a titration value of 8.5, compatible with sulfonamides and all vasoconstrictors. It is available in 0.15%, 1% and 2% topical only. It is popular for spinal anesthesia. Biotransformation takes place in the liver and end products are eliminated by the kidneys. It is chemically related to procaine, but pharmacologically it is closer to cocaine. Tetracaine is potent topical anesthetic with no significant vasodilatation property. When injected without a vasoconstrictor, produces 30 to 45 minutes of analgesia. Same concentration with 1:1 lakh epinephrine produces 75 minutes to 120 minutes of analgesia. Maximum dose recommended is 20 milligrams. It is non-irritating. Central nervous system and cardiovascular system effects are similar to those of procaine. Next, we are going to see about propoxycane. It is nothing but diethylaminoethyl 4-amino-2-propoxybenzoate used as a hydrochloride salt with a pH of 5.5. It is also a potent local anesthetic agent. Equals in potency and toxicity to tetracaine. Partially hydrolyzed in plasma. It undergoes further biotransformation in the liver. It is eliminated by kidneys. It is of rapid onset, profound anesthesia of long duration when injected close to nerve sheath. Maximum dose recommended is 6.6 milligrams per kg. Maximum total anesthetic dosage should not exceed 400 milligrams. Next, we are going to see about 2-chlorprocaine. It is nothing but beta-diethylaminoethyl 2-chloro-4-aminobenzoate with a pH of 4.8. The substitution of a chloride atom in the benzene ring of procaine causes a 4-fold in the hydrolysis rate. It is more potent and less toxic than procaine. It is rapidly hydrolyzed in the presence of plasma choline esterase. Byproducts are eliminated through the kidneys. 1.2% or 3% concentration used. It is non-irritating to the tissue. Short duration. It must be used with vasoconstrictor. It is used in children. Maximum dose recommended is 11 milligrams per kg or 800 milligrams. That is 40 ml of 3% solution. Next, we are going to see about lidocaine. Lidocaine is discovered in the year 1943 by Lofgren. It is the first non-ester type of local anesthetic agent. Lidocaine base is slightly water soluble and hydrochloride salt is readily soluble in water is the standard of comparison. It diffuses readily through the interstitial tissue and into the lipid-rich nerve. Rapid onset of anesthesia with a titration value of 7.85 favors deprotonization and produces unionized free base and production of conduction block. It is 2 times as potent and toxic as procaine. Onset time is of about 2 to 3 minutes. Duration of action depends upon the type of injection and amount of vasoconstrictor used. Effect of lidocaine in central nervous system. In toxic doses, it first produces stimulation and then depression of the central nervous system. When it is given in IV form, it is capable of producing a degree of analgesia and general anesthesia. In central nervous system, 50 to 100 milligrams given in IV during general anesthesia and surgery to correct ventricular arrhythmias. Toxic doses may lead to hypotension and cardiovascular collapse. In respiratory system, small dose has a mild bronchodilating effect. Respiratory arrest is the most common cause of death related to overdose. Lidocaine undergoes biotransformation in the liver rather than hydrolysis in the plasma. Lidocaine and its byproducts are eliminated by the kidneys. 4-hydroxy-2,6-dimethyl-aniline is the major urinary metabolite. Maximum dose recommended is 4.4 milligrams per kg. It should not exceed to 300 milligrams when not used with a vasoconstrictor, that is 7 milligrams per kg, and not to exceed 500 milligrams when used with either 1:50 lakhs or 1:1 lakh epinephrine. Dental cartridges of 2% lidocaine are available and contain no vasoconstrictor or epinephrine in concentrations of 1:1 lakh or 1:50,000. Next, we are going to see about mepivacaine. Mepivacaine has a molecular weight of 285.5. Without a vasoconstrictor, it produces pulpal analgesia of 20 to 40 minutes. It is moderately long duration of action, 2 times as potent and toxic as procaine. Currently, mepivacaine, lidocaine and Prilocking are the only dental cartridges that do not contain the germicide or preservative methylparaben, which has been implicated as the causative agent in many allergic reactions. Mepivacaine is a para-amino-benzoic acid derivative. It may also be responsible for cross-sensitivity between ester and non-ester anesthetic agents. Maximum dose with or without a vasoconstrictor is 6.6 milligrams per kg and should not exceed 400 milligrams. It is available in 3% concentration without vasoconstrictor or a 2% solution with 1:20,000 leave or different. Next, we are going to see about Prilocking. It is a derivative of toluidine instead of xylidine with the empirical formula of base C13H20N20 with a molecular weight of 220.3. When hydrochloride salts are used having empirical formula of C13H21Cl N20, it contains 86% base having a molecular weight of 256.8. 4% solution of Prilocking has a pH of 6 to 7 and a titration value is 7.9, about 40% less toxic than lidocaine. It undergoes biotransformation more rapidly than lidocaine. Orthotoluidine is a metabolite produces methemoglobin in large doses. Contraindicated in patients with congenital or idiopathic methemoglobinemia. 400 milligrams produces a methemoglobin level of only about 1% in the blood levels less than 20% rarely produce symptoms. Symptoms include cyanosis coupled with respiratory or circulatory distress. Symptoms may be reversed with IV administration of 1 to 2 milligrams per kg of 1% methylene blue. It is available in 4% solution, which without epinephrine gives 60 minutes of working anesthesia. When epinephrine in a 1:2 lakhs concentration is added to 4% Citanest, the product is called Citanest port. Duration of pulmonary anesthesia is about 60 to 90 minutes. Next, we are going to see about bupivacaine. Bupivacaine is a crystalline powder freely soluble in 95% ethanol and water and slightly soluble in chloroform or acetone with a pH of 4.5 to 6.5 and a titration value 8.1. It is amide derivative structurally similar to mepivacaine with a butyl group replacing the methyl group in the hydrophilic end. Marcaine, bupivacaine 0.5% with 1:2 lakhs epinephrine available in conventional 1.8 ml cartridge. Also supplied in 10, 20 and 50 ml vials containing 0.25% or 0.5% or 0.75% solution without a vasoconstrictor or with 1:2 lakhs epinephrine. Structural modification has resulted in the production of an agent that has 35-fold increase in oil-water parturition coefficient plus a significant increase in protein binding qualities. The net effect is a 4-fold increase in intrinsic anesthetic activity and duration of action. It is 4 times as potent and toxic as mepivacaine and lidocaine. Pulpal anesthesia is increased to 3 hours. Duration of soft tissue anesthesia may extend up to 12 hours. A period of analgesia persists after the return of other sensation, hence the need of analgesic drug is reduced or eliminated. It should not be administered to children. It undergoes biotransformation in the liver by conjugation with the glucuronic acid. Total dose in healthy adult should not exceed 2 mg per kg, not to exceed 22 mg with 1:2 lakh epinephrine or 175 mg without a vasoconstrictor. Total dose may be repeated up to once every 3 hours and not to exceed 400 mg in 24 hours. Next, we are going to see about etidocaine. It is also a white crystalline powder freely soluble in 95% ethanol and water. It has a pH of 3 to 5 and titration value is 7.7. It is also an amide derivative structurally similar to lidocaine with a propyl for an ethyl group at the amine end and addition of an ethyl group at the alpha carbon in the intermediate chain. Presently not available in a dental cartridge. It is supplied in 30 and 50 ml vials containing 0.5% or 1% solution of etidocaine without a vasoconstrictor or with 1:2 lakhs epinephrine. A 20 ml vial containing 1.5% etidocaine with 1:2 lakh epinephrine is also available. 50-fold increase in oil-water partition coefficient and almost 2 times protein binding characteristics. It is of faster onset and longer duration. 4 times increase in anesthetic activity and 2 times longer duration of action than lidocaine. It should not be administered to children. Etidocaine is twice as toxic as lidocaine. Total dose should not exceed 4 mg per kg to a maximum of 300 mg when used without a vasoconstrictor. 4.4 mg per kg to a maximum of 400 mg when combined with 1:2 lakhs epinephrine. Incremental dose may be repeated every 2 to 3 hours. Next, we are going to see in detail about topical anesthetics. Direct application to the abraded skin or to the mucous membrane surface, partly soluble in water and do not form soluble acid salts. Most common exceptions are lidocaine and tetrachine. Lidocaine is available in 5% or 10% topical anesthetics, whereas tetrachine is available in 1% or 2% concentration. Higher concentrations are required for diffusion through the mucous membrane. In addition to tetrachine and lidocaine, the most commonly used topical anesthetics are benzocaine and benzyl alcohol. It is water-insoluble topical anesthetic soluble in vehicles such as alcohol, polyethylene glycol, propylene glycol, or carboxymethylcellulose that makes them amenable to surface application. Poorly absorbed and systemic toxicity virtually unknown. In this slide, we are going to see in detail about benzocaine. It is closely related to procaine. It is an ester of aminobenzoic acid, no basic nitrogen group, hence unable to form soluble anesthetic salts. Hurricane is a commercially available aerosol that contains benzocaine. Irritating if injected into the tissue, it can produce toxic symptoms if absorbed in sufficient quantities. Next, we will see about lidocaine. Lidocaine is available in two forms, lidocaine base and lidocaine hydrochloride. Lidocaine base is insoluble in water. It is available in 5% concentration. Excellent surface anesthesia is achieved within 15 seconds of application. Single application has a duration of about 30 minutes. It is poorly absorbed. Systemic toxicity is negligible. 10% lidocaine base is available in an aerosol spray with a metered dose valve discharges 10 mg per spray. In this slide, we'll see about water-soluble topical anesthetic agents. Primary disadvantage is that a rapid absorption into the bloodstream. Example, benzyl alcohol. Benzyl alcohol is nothing but aromatic alcohol soluble in water. It is very irritating on injecting into the tissues. It is available in 4% to 10% solutions. It is of short acting and less toxic than ethyl aminobenzoate. Next, we will see about tetrachine hydrochloride. It is very potent and highly water soluble. Onset of action is slow, but duration is relatively long lasting. Frequently combined with benzocaine, an agent of rapid onset and brief duration. A mixture of benzocaine 14%, glutamine 2%, and tetrachine 2% dissolved in dipropylene glycol under the name sedation is extensively used. Maximum dose is 20 mg or 1 ml of 2% solution. We'll see about lidocaine hydrochloride. It is available in 2% or 4% concentration. Maximum recommended dose is 200 mg. When applied by means of cotton applicators, the suggested maximum dose is 1 to 5 ml or 0.6 to 3 mg per kg and not to exceed 300 mg or 4.5 mg per kg. In this slide, we'll see about vasoconstrictors and how it is produced. Tyrosine, in the presence of tyrosine hydroxylase, it is converted into dihydroxyphenylalanine, that is L-DOPA. L-DOPA is converted into dopamine in the presence of DOPA decarboxylase. DOPA, in the presence of dopamine beta hydroxylase, it is converted into norepinephrine. Norepinephrine, in the presence of phenylethanolamine M-methyl transferase, it is converted into epinephrine. The vasoconstrictors commonly used in dental local anesthetic solutions can be divided into following three groups. Pyrocataxin derivatives, that is epinephrine and norepinephrine. Benzol derivatives, example levonorepinephrine. Phenol derivative, phenylepinephrine. Mode of action. Sympathomimetic amines act by attaching to and directly stimulating adrenergic receptors. Acting indirectly by provoking the release of endogenous catecholamines. A combination of direct and indirect action. All vasoconstrictors used in conjunction with local anesthetics are directly acting agents. Epinephrine. Epinephrine is nothing but levorotatory alkaloid secreted by adrenal medulla. It is highly soluble in water. Most potent vasoconstrictors used. It is used as a standard of comparison when it has a potency of 1. Concentrations from 1:50,000 to 1:250,000 are used. In the cardiovascular system, beta-1 stimulation results in an increase in heart rate, that is positive chronotropic effect, increase in stroke volume, cardiac output and oxygen consumption, increased irritability of myocardium, premature ventricular contractions and tachycardias. Other effects are increased blood glucose levels, increased glycogenolysis and pupillary dilation. Norepinephrine. It is a major pressure amine found in the postganglionic adrenergic nerve. White crystalline salt freely soluble in water with a pH of 3.4. It has no radical on the amino group. It acts predominantly on the alpha receptor site. Dose should not exceed 0.34 mg or 10 ml of solution containing 1:30,000. Levonorepinephrine. It is 1/5 as active as epinephrine. Lower systemic toxicity. It acts directly and almost exclusively on the alpha receptor sites. Dose. When 1:10,000 concentration is used, it should be limited to a total dose of 1 mg. Patients with cardiac conditions, its use should be limited to a maximum of 0.4 mg. Phenylephrine. Similar to epinephrine but differing structurally. It has only one hydroxyl group on the benzene ring. It is most stable and weakest of all vasoconstrictors and long lasting. Used in concentrations 10 to 20 times dose of epinephrine, 1:2500. It is a pure alpha receptor agonist. Dose 1:2500, limited to 4 mg at one time. In patients with cardiac conditions, it is reduced to 1.6 mg. Termination of action and potential drug interaction of vasoconstrictors are: tricyclic antidepressants interfere with the reuptake mechanism, deactivation by extraneuronal enzyme, example catechol O-methyl transferase, uptake by the blood system, intraneuronal enzyme destruction, monoamino oxidase inhibitor, alpha adrenergic blockers such as phenothiazine, epinephrine reversal effect, beta adrenergic blockers, example propranolol, inderol. Selection of vasoconstrictors. Duration of desired effect, physical condition of the patient, desire to produce hemostasis, concurrent medication. Properties of ideal local anesthetic agent: reversible action, non-irritant, no allergic reaction, no systemic toxicity, rapid onset of action, sufficient duration of action, potent, stable in solutions, not interfere with the healing of tissue, have a vasoconstrictor action or compatible with vasoconstrictor, not expensive. To conclude with local anesthetic agents, the table depicts the maximum dosages allowable for the administration of infiltrative local anesthesia. Next, we will see about general anesthesia. In general anesthesia, the learning objectives are to know briefly about various types of dental surgeries, to discuss about anesthetic techniques for dental surgeries, to discuss various techniques of airway management in facial maxillary surgeries, to discuss about the anesthetic concerns and management of facial maxillary surgeries. What are the types of dental surgery? Endodontic surgery involving the pulp or root of teeth. Prosthodontic surgery involving dental prosthetics. Orthodontics primarily surgery of malpositioned teeth and jaws. Episectomy surgical procedures that can be performed to save a tooth. The most common is root end resection. Periodontics the placement and maintenance of dental implants. And facial-maxillary surgery. Types of facial-maxillary surgery. Oral surgery includes dental extractions, orthodontic exposures, implants, and oral procedures for mouth lesions including cysts, infections, and salivary gland diseases. Many of these diseases can be done as a day cases. Trauma surgery provides surgery for facial injuries including open reduction and internal fixation of the zygomatic and mandibular fractures and close reduction of the nasal fractures. These procedures may involve extra or intraoral lesions with plating. Craniofacial surgery involves orthodontic and aesthetic procedures for facial bone deformities. This includes Leaford maxillary osteotomies, mandibular osteotomies, and advanced genioplasties. Cancer surgery involves surgical resection of head and neck cancers and reconstructions, including bone grafting and microvascular free tissue transfer. Dental anesthesia. Outpatient anesthesia, dental chair anesthesia or office-based anesthetic care, simple tooth extraction can be carried out in, especially in children. Day case anesthesia, patient goes through formal admission to hospital but is discharged home later in the day. Usually adults. Procedures conducted during day case anesthesia are limited dental extractions such as those of impacted wisdom tooth. Minor oral surgical procedures. Inpatient anesthesia is nothing but major oral and maxillofacial surgeries involving major orthodontic surgery for skeletal malocclusion, facial trauma and fractures, example mandibular fractures, midface fractures, radical cancer surgeries, example maxillectomy, mandibulectomy. Anesthetic technique. Topical local infiltration using local anesthetics, regional blocks, conscious sedation, general anesthesia. Local infiltration generally performed by the operating dentist. Local anesthetic solutions with or without adrenaline used to perform various infiltrative techniques and nerve blocks. These may be combined where appropriate with conscious sedation or topical anesthesia. Some of the local anesthetic agents used for local infiltration are Lidocaine 2% plain, Prilocking 3% with velipressin 0.03 international units per ml, Articaine 4% with epinephrine, Bupivacaine 0.25 to 0.5% plain. Oral nerve block. Some of the indications for oral nerve block are dentalveolar abscesses, toothache, pulpitis or root impaction, orofacial laceration repair, example tongue, lip mucosa, post-extraction pain including dry socket, dentalveolar trauma or fractures, mandibular and maxillary fractures. Where conscious sedation is used, the patient must retain their protective airway reflexes and be able to respond to and understand verbal communication. The drugs and techniques used must therefore carry a margin of safety wide enough to make loss of consciousness. Example, in anxious patient in combination of nerve blocks with local anesthesia when complex dental work is undertaken. Types of sedation: inhalation sedation, intravenous sedation, oral sedation. Next, we'll see about general anesthesia. It is required for three main groups of patients: patients with learning difficulties, for extraction of permanent molars, more complex or extensive dental work, inpatient anesthesia for maxillofacial surgery, example congenital, cosmetic, traumatic, and neoplasm. Criteria for giving general anesthesia: patient inoperatory with preoperative instructions followed. Check for the vital signs and evaluate the status of the health of the patient. Pre-medication, induction of general anesthesia, intraoperative monitoring, reversal of anesthesia in indoor unit, post-operative instructions and follow-up. Drugs used for anesthesia, it is classified into inhalation and intravenous. In inhalation anesthesia, example nitrous oxide, volatile liquids such as ether, halothane, isoflurane, desflurane and sevoflurane. In intravenous anesthesia, inducing agents, example thiopentin sodium, methohexytone sodium, propofol, etomidate. Slower acting drugs, example diazepam, lorazepam, midazolam. Dissociative anesthesia, example ketamine. Opioid analgesics, example phentermine. We will discuss about some of the inhalational anesthetic agents. Example, sevoflurane. Sevoflurane supplementation of 66% nitrous oxide in oxygen is used. Sevoflurane may either be introduced in 2% increments every 2 to 3 breaths to a maximum of 8% with maintenance of anesthesia at around 4%, or it may be introduced at maximum concentration of 8% with maintenance at 4%. Sevoflurane became available, and in comparison to halothane, it is associated with less myocardial depression and fewer and less significant respiratory problems when used for inhalational induction. Next, we will see about diethyl ether. Diethyl ether produces good analgesia and marked muscle relaxation. It is highly soluble in blood. Recovery is slow. Post-anesthetic nausea and vomiting will be there. Ether is not used in developing countries because of its unpleasant and inflammable properties. Next, we'll see about nitrous oxide. It is colorless, odorless, heavier than air, non-inflammable gas. Onset of action is quick and smooth. A mixture of 70% nitrous oxide with 25 to 30% of oxygen plus 0.2 to 2% another potent anesthetic is employed for most surgical procedures. In this way, concentration of other anesthetics can be reduced to 1/3 for the same level of anesthetic. Intravenous sedation. In intravenous sedation, methotrexate sodium is a ultra short-acting barbiturate with rapid onset. IV dosage of 0.75 to 1 mg per kg produces sleep-like state without spontaneous movements within 1 minute. Patient may wake up in 10 minutes. Diazepam or lorazepam dosages in oral form 0.2 to 0.5 mg per kg to a maximum single dose of 10 mg. In IV form 0.25 mg per kg. It is supplied in tablets as 2, 5 and 10 mg. Suspension as 5 mg per ml. Midazolam dosage oral form 0.25 to 1 mg per kg to a maximum single dose of 20 mg. IM 0.1 to 0.15 mg per kg to maximum dose of 10 mg. IV form slow IV titration. See manufacturer's recommended dosage lines. Supplied in syrup as 2 mg per ml. Injectable 1 mg per ml and 5 mg per ml vials. Fentanyl. Onset is 30 seconds in IV form and 5 to 10 minutes in IM form. Peak effect is 10 minutes in IV and 30 to 45 minutes in IM. Duration of action is 30 to 60 minutes. Dosage 0.002 to 0.004 mg per kg. Supplied as 0.05 mg per ml in 2 and 5 ml ampoules. Ketamine induces so-called dissociative anesthesia. Dose is 3 mg per kg in IV form or 5 mg per kg in IM form. Recovery starts within 10 to 15 minutes, but patient remain amnesic for 1 to 2 hours. Next, we'll see about propofol. It is fast-acting agent. It is also called as milk of amnesia. Veer Cum et al. In the year 1997 published an account of an exploratory study where children mainly with nursing bottle caries had teeth removed using propofol administered by an anesthetist. In IV form, 2.5 to 3.5 mg per kg should be used. In oral dosage, it is 50 mg per kg with a range of 40 to 60 mg per kg. Duration of action is 2 to 5 hours. Reversal agents. Specific reversal agents exist for benzodiazepines and opiates. Flumazenil 0.01 mg over 15 seconds may be repeated at 1 minute as needed. Naloxone 0.4 mg initially followed by 0.1 to 0.2 mg every 2 to 3 minutes. What are all the pre-medications used before general anesthesia? Drugs, opioids, dosage, morphine 10 mg, bethadine 50 to 100 mg, route of administration IM. Features: it reduces anxiety, produces pre and post-operative analgesia, reduces the dose of anesthetic required. Disadvantages are depressed respiration, fall in BP, lack of amnesia, delayed gastric emptying. Sedative anxiety, diazepam 5 to 10 mg, lorazepam 2 mg, administered either in oral or IM form, produces tranquility and smooth induction. Disadvantage is that loss of recall of post-operative events, accentuation of post-operative vomiting. Anticholinergics, atropine 0.6 mg IM to reduce salivary or bronchial secretions. Disadvantages: dryness of mouth in pre and post-operative period may be distressing disadvantage. Neuroleptics, chlorpromazine 25 mg, haloperidol 2 to 4 mg, IM, allay anxiety and antiemetic action. H2 blockers, ranitidine 150 mg, oral, used for long procedures, cesarean section, obese patients at increased risk of gastric regurgitation. Antiemetics, metoclopramide 10 to 20 mg, IM, effective in reducing postoperative vomiting. Disadvantages is motor restlessness. Various routes of administration of anesthesia: intravenous, inhalation, intramuscular, oral. Intravenous anesthesia: by securing the needle in the vein throughout the surgical procedure, the solution can be given intermittently. Inhalation: technique of administration in which a gaseous or volatile agent is introduced into the lungs. Intramuscular parenteral administration of drugs for sedation requires additional training and skill. Oral, a technique of administration in which the drug administered through the mouth. Stages of general anesthesia. Given near 1937 classified into 4 stages. Stage 1, stage of analgesia. Stage 2, stage of delirium. Stage 3, stage of surgical anesthesia. Stage 4, stage of respiratory paralysis. American Society of Anesthesiologists classified patient physical status as ASA1, a normal healthy patient, ASA2, a patient with mild systemic disease, ASA3, a patient with severe systemic disease, ASA4, a patient with severe systemic disease that is a constant threat to life, ASA5, a moribund patient who is not expected to survive without the operation, ASA6, a declared brain dead patient whose organs are being removed for donor purposes, E, emergency operation of any variety used to modify one of the above classifications, that is ASA3E. These are the stages of general anesthesia in stage 1, stage 2, stage 3 and stage 4, where we will see about the diaphragm and intercostal movement, ocular movement, pupils with no medication, eye reflex, pharyngeal and laryngeal reflexes, secretion of the tears, muscle tone, respiratory response to skin incision. Advantages of general anesthesia. Patient's cooperation is not absolutely essential for the success of general anesthesia. Patient is unconscious. Patient does not respond to pain. Amnesia is present. General anesthesia may be the only technique that will prove successful for certain patients. Rapid onset of action. Titration is possible. Disadvantages of general anesthesia are the patient is unconscious, protective reflexes are depressed, vital signs are depressed, advanced training is required, an anesthesia team is required, special equipment is required wherever general anesthesia is given. A recovery area must be available for the patient. Intraoperative complications are more likely to occur during general anesthesia than during conscious sedation. Indications for general anesthesia: extreme anxiety and fear, adults or children who have mental or physical disabilities, senile patients or disoriented patients, age also infant, children and aged patients, short and traumatic procedures, prolonged traumatic procedures. Contraindication of general anesthesia: lack of adequate training by the doctor, lack of adequate trained personnel, lack of adequate equipment, lack of adequate facilities, ASA4 and a certain ASA3 medically compromised patients. Monitoring equipments during general anesthesia are pulse oximeter, sphygmomanometer, temperature, precordial stethoscope for monitoring heart sound, pretracheal stethoscope for monitoring respiration. Airway management in facial-maxillary surgery. Choice of airway management technique depends on several factors. Patient factors, known difficult airway, experience of the anesthetic and anesthetic preferences, surgical requirements, nasal or oral, ultimately depends on the patient's safety. For airway management, there are several factors should be taken into consideration. They are history, physical examination, further evaluation, difficult airway algorithm and airway strategies. In history, in case of trauma surgery, history of mechanism of injury to assess for the potential of other injuries. Tumor or cancer surgeries, previous head and neck surgery may be showing altered anatomy. Long-term tracheostomy shows tracheal stenosis. Post-wise or symptoms of stridor suggest a narrowed supraglottic space. If dyspnea is a symptom, try to ascertain if it is cardiac or respiratory in origin and if it is affected by position. Squamous cell carcinoma of the head and neck affect oral cavity, oropharynx, hypopharynx and laryngopharynx. History of radiation therapy, fibrosis distort airway or make magnifications difficult. A history of radiation therapy alters tissue quality, direct laryngoscopy more difficult. Congenital anomalies. Craniofacial abnormalities should be appreciated with consideration for congenital syndromes in children and in older patients with unresolved abnormalities. Example, cleft palates or lip may be associated with Peary-Robin or Treacher-Collins syndrome, maxillary dysostotic with golden heart syndrome. If nasal intubation is a possibility, nostril patency, history of nasal polyps or deviated nasal septum, history of epistaxis or bleeding tendency and use of anticoagulants. Also assess for contraindications to hypotension, example cerebrovascular, renovascular and moderate to severe coronary artery disease. Physical examination. Besides from general and systemic examination, detailed airway assessment is must. Airway examination, inspection for obvious problems, mouth opening, oral cavity examination, interincisors gap, Mallampati score, thyromental distance, sternomental distance, neck movements. The table depicts the airway assessment. MONS represents M for mass seal, O for obstruction or obesity, A for age more than 55 years, N for noting, S for stiff lungs or C-spine, RODS, R for restricted mouth opening, O obstruction, D disrupted or distorted, S for stiff lungs of C-spine, lemon for intubation, L for look, E for evaluate, 2 score, M for Mallampati, O for obstruction or obesity, N for neck. Short surgical airway assessment, S surgery, H for hematoma, O for obesity, R for radiation and T for tumor. Further evaluation, direct or indirect fibrolaryngoscopy, Imaging, X-ray, chest, cervical spine. For cancer surgery, nasoendoscopy provides valuable information about the upper airway anatomy. Ultrasound, computerized tomography, and magnetic resonance imaging scans may be helpful in cancer, infections, abscesses, or trauma cases. Difficult airway algorithm in case of awake patient, awake laryngoscopy, awake fiberoptic tracheostomy, retrograde intubation can be carried out. Whereas in case of GA or sedation, different laryngoscopes can be tried. Fiberoptic tracheostomy and blind nasal intubation can be carried out. Airway strategies: laryngeal mask airway, tracheal intubation, oral intubation, nasal intubation, retromolar intubation, submental intubation, retrograde intubation, fiber optic aided intubation, transtracheal catheter and jet ventilation, planned tracheostomy. Conduct of anesthesia for facial-maxillary surgeries: preoperative assessment should be done. All patients require an appropriate and adequate preoperative assessment to define the extent of disease progression, in particular looking for indicators of potential airway compromise, anticipated difficulties in airway management, and significant comorbidities, and selected pathological conditions that influence airway management. Example, cervical instability in trauma, associated hemodynamics instability if associated. Concerns, airway difficulties, other congenital anomalies, other concerns regarding trauma if traumatic, sharing of airway, intraoperative blood loss, postoperative airway problems, airway edema. Monitoring and equipments: minimum ASA monitoring standards must be met to confirm tracheal intubation, to detect disconnection, detect venous air embolism, urinary output monitoring in extensive surgery. A full range of resuscitation equipment and drugs must be available. Difficult airway trolley should be checked and immediately available. Invasive lines, neck dissection, major prolonged surgery. Intraoperative concerns and management: eye protection, pads, shields, and surgical covers, remote location in related to airway, adequate fixation of the airway and circuit connections. For north-facing tubes or laryngeal mask airways, gauze padding on the forehead under nasal tubes and secure in a low-profile position. South-facing airways taped securely away from the surgical site, tube holders to stabilize the circuit. Airway edema can be taken care by the injection of dexamethasone. Positioning: once drapes are applied to the patient, it is difficult to regain access. The head supported and stabilized in a horseshoe support or head ring with a bolster on the shoulders to help extend the neck. Pressure points protected and vascular access points made accessible. Anti-emesis, anti-emetic drugs such as ondansetron and dexamethasone can be given. For the blood trickling down the larynx or trachea, lower airway needs protection against soiling from blood and debris intra and post-operatively, so that packing of the pharynx with damp gauze should be done. Substantial blood loss may occur because of the extensive blood supply to the midface. Methods to decrease the substantial blood loss are slight head-up positioning, controlled hypotension, local infiltration of adrenaline intravenously, and tranexamic acid 1 grams. Emergence and recovery: neuromuscular blocking agents antagonized as appropriate. Oxygen 100% should be administered and any anesthetic agent should be discontinued. Extubation can occur with the patient in deep while spontaneously breathing. Pharyngeal packs should be removed and the pharynx cleared of secretions and debris by suction. Blood clot should be aspirated, especially behind the soft palate, the so-called coronus clot. The patient should be turned into lateral position, possibly with a degree of head down tilt to encourage the drainage of the blood or secretions away from the larynx. Possibility of post-operative tissue edema, careful assessment of the tongue and pharynx should be tested, and also cuff-link test should be carried out. Post-operative management should be carried out with supplemental oxygenation, adequate pain control with opioids, NSAIDs, acetaminophen, post-operative nausea, vomiting issues tackled with antiemetics, airway problems continuously monitored for airway edema, hematoma, compressing neck in case of surgery involving neck. Patient may need ICU or HDU with invasive monitors in extensive or complicated procedures. Dental wire cutter always with the patient if wired. Airway compromised state, continue intubation and mechanical ventilation post-operatively. Ongoing or extensive bleeding may need to be replaced. Fluid and electrolyte supplementation and nutritional supplement. Thank you for your kind attention.